Hey everybody, welcome to the second episode of Morning Report Emergency Medicine. I'm Alec Weir. Thank you so much for all the feedback on the first episode. Hopefully we'll get some of those AV issues ironed out. This is the case of, do you have a PCP? The 44-year-old man who comes in with a chief complaint of shortness of breath as well as a cough. You see his vitals here, a little tachycardic, blood pressure 101/73, but he's pretty tachypnic at 29 and satting only 85% on room air, no fever. On chart review, you find that he's got a history of AIDS. His last CD4 count was in the 500s, but it's been 3 years since anyone's checked it. And that AIDS diagnosis came when he was also diagnosed with Kaposi sarcoma. When you go talk to the patient, he says he's been feeling sick for about 4 weeks, but he only admits to a cough, productive of white sputum, and some rhinorrhea, denies all other complaints. But he does mention, I haven't taken my heart medication in 1 or 2 months. So your resuscitation and workup, ABC's always the right answer. His airway's intact, he's talking to you. He is tachypnic, and he's hypoxic on room air, so we'll start him on a little bit of oxygen, give him some IV fluids for that tachycardia. You send off your labs, you start your workup, concern for sepsis, you send cultures and a urine. I haven't quite figured out how to upload ultrasound images yet, so I'll describe the ultrasound to you. On his echo, no massive RV dilation, which is a PE is a concern because HIV is a prothrombotic disease. He's got good LV squeeze on the echo as well. IVC is collapsible with respiration, but on his thoracic ultrasound, he's got a significant amount of B lines on both sides. Something you'd see was sort of pulmonary edema, all right? Especially when it's on both sides. EKG and chest x-ray are ordered. Anything else special you want to get on an HIV patient with a cough? While you're thinking about that, the x-ray tech hits you in the back of the heels with her x-ray machine, and you get out of the way, and you end up with this. All right? X-ray here shows this bilateral reticular opacities. All right? Worse on the left here than on the right, and as you can see, we've got air bronchograms, but bilateral reticular opacities. What were those tests you wanted to order? Yeah, you look at the x-ray, you want to send off the LDH and the CD4. They come back, your LDH is 516. Normal at our hospital is around 200 units per liter, so we're more than double that. And a CD4 count of only 16 today. So what do we got? We got Pneumocystis, right? PJP, formerly known as PCP. What is it? It's a yeast-like fungus, and also the most common AIDS-defining opportunistic infection. It does have some extrapulmonary features, none of which were present on our patient today. And then it has those classic chest x-ray findings of the bilateral reticular opacities. But, unfortunately, the chest x-ray can be normal in PJP. And your most common lab findings, like we had in our patient, the low CD4 and the elevated LDH. And with that LDH, you got to remember it's sensitive, but not very specific. And again, here's that classic bilateral reticular opacities. But remember, it can be normal. How do we treat it? Trimethoprim sulfamethoxazole, right? For the rest of this lecture, known just as Bactrim. So we also added broad-spectrum antibiotics for concomitant bacterial pulmonary infection, given the left side of that chest x-ray. And then steroids. Who gets them? When do they get them? Is there any way to guide us on this? The classic teaching is a PaO2 of less than 70. So am I telling you that we got to get an ABG on all these patients to check their partial pressure of arterial oxygen? Your medicine team will want it, but no, we don't have to do that. We can use the 40-50-60, 70-80-90 rule. If on your pulse ox your SpO2 is 90%, that correlates with a PaO2 of 60. If your pulse ox on the monitor is reading 80%, that correlates with a PaO2 of 50, and so on. So an SpO2 on the monitor of around 93% correlates with a PaO2 of about 70. And so the classic teaching, less than 70, should get steroids. Some will tell you if you're giving Bactrim, you should give steroids. And why? Why do we add the steroids? Because pneumocystis doesn't go down without a fight. So it helps to tamper that cytokine release and that inflammatory response from fungal death. That's what the steroids help do. So take-home points. Think PJP. All right? HIV patients, it is the most common AIDS-defining opportunistic infection. So remember to send that LDH and CD4. Your chest x-ray can be the classic bilateral reticular opacities, but it can be normal. And then steroids. Who gets them? Classic teaching, PaO2 of less than 70. Although some will tell you if you're giving steroids, or if you're giving Bactrim, you should give steroids. And then when do you give them? It doesn't matter. It doesn't have to be before or after the antibiotics. You can give them at the same time. All right, guys. Thanks for listening, and keep your eyes open for those interesting cases.